Hello. BPH is one of the most common medical diseases among elderly male. Today, with the trend towards the decreased incidence of surgery and growing demand of medical treatment, medical doctor other than urologists may be responsible for diagnosis and management of BPH treatment. In European countries and United States, BPH patients are commonly managed by non-urologists. Usually, primary physician and family medicine specialists diagnose and treat BPH patient and play a role of gatekeeper in referral system. Many BPH patients are also managed by non-urologists in Korea. However, Korea's healthcare system is quite different than that of other countries. Most of physicians are specialists, and these specialists are responsible for primary health care. In addition, patients can decide whether to visit urologist or non-urologist according to their preference, rather than the referral system. Although this situation could give rise to many problems, today there has been little research on these issues. In current study, we analyzed the current status of BPH management in Korea and the difference in BPH management between urologists and non-urologists. Here, I'd like to introduce Dr. Park, the first author in this study. He will summarize the method and result for this study. Dr. Park, please.
Hello, I'm Dr. Park from Seoul National University Hospital. I will introduce our study, material and method, and result in the study. We obtained data from 2007 to 2011 from Health Industry Representative Association. The diagnosis of BPH at clinic or hospitals were based on the application of BPH code. The initial BPH patient was defined as not having been assigned a BPH code within the last 2 years. The patient with inflammatory prostatic disease and prostate cancer were excluded. Those with Parkinson's disease, multiple sclerosis, cerebral palsy, stroke, and other paralytic syndrome were also excluded. About 391,000 individuals were defined as new BPH patients in 2009. Of these, about 60% patients were diagnosed by urologists and 40% patients were by non-urologists. Among the non-urologists, internist and family medicine were the common. The basic characteristics between urologist group patients and non-urologist group were quite different. Age, comorbidity, area, hospital, and the insurance classification were significantly different. The initial diagnostic evaluation of new BPH patients were significantly different between the two groups. The rate of all tests except serum creatinine were lower in the non-urologist group. The rate of drug prescription after initial diagnosis were higher in the urologist group, where the periods of drug prescription were longer in non-urologist group. In the analysis of kinds of med drugs, the use of alpha blocker were common in both groups. Urologists prescribed combination therapy of an alpha blocker and with a 5-alpha reductase inhibitor as the second choice, whereas the non-urologist preferred monotherapy with a 5-alpha reductase inhibitor.
Thank you for nice presentation, Dr. Park. In this study, the course of initial evaluation was revealed significantly different between two groups. Although difference in hospital facility and environment may affect the evaluation, the rate of all basic tests except serum creatinine were significantly lower in non-urologist group. The findings suggest that non-urologists skipped a number of essential diagnostic tests for BPH. In contrast, urologists conduct many tests not covered by insurance in addition to basic tests. The present study is a real-world study reflecting current BPH management in Korea. It revealed a distant gap between urologists and non-urologists in diagnosis and treatment of BPH. This gap may have serious implications for the management of BPH patients. The Urology Society should arrange ongoing training program for management of BPH for non-urologists as well as urologists. Thank you very much.